Because like I said, testing for antibodies in people who've recovered could tell us something reassuring about whether we really are facing imminent death from this virus if ever we leave our homes, like that ABC hysteric suggested. Now, in fact, there have been such antibody testing overseas. One such test in California, in Santa Clara, was done by Stanford University, one of two. Joining me a short while ago was a professor of medicine at Stanford, Jay Bhattacharya. Professor Jay Bhattacharya, thank you so much indeed for your time. Can you tell us what your study found?
So I've done a couple of studies, one in Santa Clara County in California and another in Los Angeles County. What we found is that roughly about 3 to 4% of the population in these counties have shown evidence of antibodies to COVID-19, specific to the virus that causes COVID-19. What that means is that roughly, say, 50 times more people have had the disease than we've realized based on case counts alone. That also means that the disease is less deadly than we realized. It's more on the order of 1 in 1,000, 2 in 1,000 fatality rate, rather than 30 in 1,000, which is what the World Health Organization originally said.
These are really interesting figures, and the first time I talked to you, and this is some time ago, you suggested that the mortality rate might come down to something akin to the flu, and if these results are accurate, then it seems you were right. Why are these figures so important when we're talking about things like, you know, can we develop a herd immunity, for instance, you know, get enough people infected and then recovered so that the virus then finds it very hard for a second wave to get started because there's not enough people that it can infect who then pass it on?
Yeah, I mean, I think for one, I mean, it's not that many people, right? It's three in that sense. A herd immunity would require a very substantial fraction of the population to be infected. We're finding 3 or 4% in most of the country outside of New York. Even New York, 25%. Herd immunity require 60, 70%. I mean, much larger fractions. So if herd immunity is a strategy, we're very, very, very far away from that.
There have been concerns about the reliability of antibody testing. In Britain, they've had to junk a whole lot of test kits they got from China. In Australia, our government hasn't started its own testing yet. With your own tests, how confident are you in the reliability of the tests themselves and in the sample that you've used?
So I think the concern about these tests is that there's two kinds of errors. One is that they can generate false positives, which means that if you're truly antibody negative, that the test shows positive. And then the other is that they can show false negatives, that if you're truly positive, it doesn't pick up that you're positive. The tests are fantastically good at avoiding false positives. They're 99.5% specific, meaning that they have only a 0.5% false positive rate. You can't use the false positive to explain our results. We found this basically over and over in a whole series of studies using this test kit. It's fantastically good at that. The false negative rate, it's about on the order of 80%, 20%. So 80% sensitive, which means 20%. Now that you can correct very easily in large population studies like we do. So just to give you an example, if I had a kit that was really bad, that's only 50% sensitive, what I could do is say for every positive I find, there's another positive that out there I didn't see, and that's enough to correct. I can just do a very simple statistical correction. So for epidemiologic work, it's fantastic. These kits are very, very accurate and completely useful for studies like mine. For clinical work, where I'm going to say, okay, you're positive, well, those errors might be too many for me to confidently say you're positive. So I think there's this distinction between use in clinical studies, clinical work, versus, where I'm diagnosing one patient, I can't do a statistical adjustment, versus a large population where I can very easily do a statistical adjustment. These tests are actually quite accurate, despite the statistical criticism some have levied at them.
And how do your results fit in with some research I've seen, a Cambridge University study suggesting that the parent form of the virus might have been out and about in China as early as September, given the time it takes to mutate into the types that were found in Wuhan. That's 3 months earlier than the Chinese first case in Wuhan. And in France, a doctor's saying, well, he treated a patient as early as December for suspected pneumonia, retesting, found that it was COVID-19. That's not been confirmed, but that too would be 1 month earlier than the first recorded official case in Europe. How do your results fit in with those ideas that the virus was out there probably a bit sooner than we even thought?
Right, so even in Santa Clara, where we did our study, there was a coroner's report about for a case of someone who died on February 6th. That ex post we found that actually had the virus. February 6th, roughly, that's, if you go back, had to have been at least 3 weeks before, when it was, the time from infection to death is roughly about 3 weeks on average. That's before the earliest case in the U.S. That's consistent with the results we have in the sense that the epidemic is more widespread than we think. That means it must have taken more time to reach that state than we realized. So if we have a very early date, a very late date for the virus, that poses a puzzle. How could it be so widespread? But if we have an earlier date, which is consistent with the evidence from autopsies, then I think that's completely consistent with the results that we've seen in the antibody studies.
Professor Jay Bhattacharya, you've done some absolutely fascinating work. Thank you so much indeed for your time.
Thank you, Andrew. It was a pleasure to be here.